We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ASHRAE.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Jesse, how are you?
I'm great. How are you?
I'm good, my friend. It's so good to hear your voice as always. How is everything up in New Hampshire?
It's good. It's, we're coming into our summertime, which I'm not sure it'll be a real summertime. It's not all that warm yet, but hopefully for the beach next week, we'll get some of that sunshine and heat.
Absolutely. So speaking of beaches and stuff, do you know where sharks go on vacation?
Hopefully not up here, but where?
It's a ways away. They go to Finland. Yay. Okay, well, have fun on vacation. Let's jump right into it, shall we?
Yeah.
So today we're talking with Dr. John Harp, and we are going to talk to him about his article, Observational Study of Sterile Field Bioburden Levels During Orthopedic Arthroplasty Surgery in Operating Rooms Complying with Current United States Ventilation Specifications. So we're excited to have him. Dr. Harp has worked as a civil engineer for 10 years before attending medical school in Arkansas. He worked as a research engineer on several orthopedic projects during medical school and during his orthopedic surgery residency in Little Rock. And after seeing one of his patients experiencing treatment for a deep paraprosthetic joint infection, Dr. Harp turned his engineering and research experience toward the topic of airborne microbial contamination in the operating room. Dr. Harp started his independent study of this topic with the mentorship of Dr. William White, an international expert on the topic and co-author of the pivotal Medical Research Council study in 1982. Dr. Harp's focus has been the introduction of well-known industrial cleanroom techniques into the operating room with the goal of improving patient safety through reduction of PJI risk after total hip and knee replacements. Dr. Harp currently works at Baptist Health Orthopedic Clinic in Fort Smith, Arkansas, and his practice focuses on adult reconstruction surgery. So welcome, Dr. Harp. We are so excited to have you on today.
Thank you for the opportunity to speak with your listeners.
Absolutely. So kick us off, if you don't mind, and tell us what prompted the study.
Well, as you stated in the intro, I have training both as an orthopedic surgeon and as an engineer. And as an orthopedic surgeon, I had one of my surgeries, experience a deep periprosthetic infection. That requires 2 additional surgeries for an 85% chance of cure of the deep infection. And as you know, these deep infections cannot be eradicated by IV antibiotics because the bacteria will adhere to the implants and form a biofilm, and therefore the implants have to be removed. And then the third surgery, if you look at it from the very beginning, is required to put in a new implant. And that treatment only has an 85% success rate. So if you're one of the 15%, your journey is not ended. There's still more ahead of you. So this is a terrible complication.
You know, that's an interesting statistic. I did not know that. I didn't know that there was only an 85% success rate. So thank you for sharing that.
Yeah. And as an engineer, when I looked at the problem, my first question is, well, how do you know what the air quality is? And that's started my journey, and over 1,000 articles in my literature review database and hundreds of technical reports and conversations with Dr. White. I produced a first paper, which was a technique paper, and then this second paper is the actual pilot study.
Very cool. So Dr. Harp, in the article, it noted that approximately 43,000 patients in 2022 were affected by prosthetic joint infections, and that this number is actually expected to increase to 66,000 patients by 2030. Do you believe this to be in part due to these microbe-carrying particles that were described as part of this observational study?
Yes, and unfortunately, the data is not generally available in how to subdivide that 43,000. In general, in orthopedics, a infection within the first 90 days after surgery is thought to be related to something in the operating room. And after 90 days is thought to be more likely hematogenous and due to external causes not related to the surgery. So first of all, we don't have a number to tell us exactly what is that 90-day rate. And this, as you know, surgical infection rates are very tightly guarded data, and I have not seen sufficient data to make any kind of comment on the percent due to the first 90 days. Second, the intraoperative contamination possibilities are very complicated. There's multiple sources, and there are, again, no good numbers. However, whatever that number is, airborne air quality is as far as I can tell from my assessment, the only uncontrolled portion of whatever that intraoperative risk is.
So, Dr. Harp, the article mentions the ASHRAE 170 standard from 2021. So, for those of us that aren't familiar with the standard, can you give us a high-level overview and just kind of explain what the standard is and how it relates to your work?
ASHRAE is a national organization for heating and ventilation engineers, and they produce, through their process, a very detailed specification for HVAC systems in hospitals and healthcare facilities. It is available for adoption in the United States, I guess, or anywhere. It's really unknown how many states adopt it or what detail. This specification has the main variables specified for a ventilation system in operating room, protective environment areas in the hospital.
So let's go a little further into some of the operating room specifics. Can you describe what critical zone contamination looks like?
The critical zone is a term I borrowed from the cleanroom technology, and that is the area with the highest risk of damage to the end product in an engineering sense. This, for example, in pharmaceutical manufacturing, this is the vial as it's being filled with a drug in an aseptic environment. And for that instant that occurs, it's exposed to a larger environment. So in that particular example, that's a critical zone. What I used as a critical zone in operating room is the open wound where we're putting in a knee replacement or a hip replacement and the surrounding sterile field.
Mm-hmm. Mm-hmm.
That's really interesting. And so you were talking about the clean room. And so the article actually describes clean room principles, specifically two major classes of air particulate matter that can be measured, viable and non-viable. And in this study, only the viable particulate matter was measured. How was this measured, and why did you select the method that you did for measurement?
Well, my approach is from a practical approach as a surgeon. What can I measure most efficiently at the least cost? And what is most related to the risk of infection? So I chose, of all the available techniques, first of all, a viable particle. So that particle has the possibility of causing an infection. Non-viable particles could represent lint, other aerosols in the room that even though you'd want to exclude them theoretically from a wound, really don't have a direct effect on infection risk. So I zeroed in on the one thing, and my back the envelope critical zone risk assessment was the highest risk related to a deep infection.
And then how were the particles measured?
So I used a settle plate technique, which is the traditional Petri dish that is considered a form of passive measurement. And the microbiologists I've talked to think it's pretty primitive. However, it's very elegant in that if you think of it, you're exposing a sterile media, the agar in a Petri dish, to the exact same air environment that the sterile field right next to the Petri dish is also experiencing. So the particles that land on that plate and the viable ones and again, it's such a different type of science. Not all the viable particles will actually grow, but the ones that do give me some assessment of what viable particles per area of the Petri dish have occurred during an operation.
Yeah. So in thinking about that, how did you determine what the baseline for the microbe carrying particles in the rooms was? Did you do, the settle plates during times where there were no cases running, or in an empty room with no people coming in and out, that sort of thing?
I actually did some testing, and in the clean room technology that's called at rest is when there's no people in the room, the HVA system is on, and the measurements you get then are zero. And in the vast majority of circumstances, it will be zero. The issue is not the air coming into the room, it's what happens to the air once it's in the room. So the second part of that baseline was developed is a 450 microbe carrying particles per square meter, and that I derived in the earlier technique paper based on a volumetric standard of 10 MCPs per cubic meter, which your listeners are probably more familiar with if they've looked at any of the ultra clean air literature.
Mm-hmm.
Interesting.
Yeah, it is very interesting. And you're right. It is an elegant method of collection. And I'd like to talk a little more about the air quality, if you don't mind, because the article notes that room air temperature and airflow rate, humidity, pressurization relative to the entryway, all those were monitored continuously. So could you tell us a little more about how temperature and humidity can impact microbe carrying particles dispersion and measurement? And along those same lines, were the doors to the ORs maintained closed for the duration of the cases?
Yes, in these 80 cases we did I have a very strict control. I was a surgeon or part of the team in a lot of the cases, and we were very strict, and the crew is very observant of minimizing the amount of traffic in and out of the room. So although I can't, the doors weren't closed 100% of the time, we have a strict protocol against entering and leaving the room. Furthermore, the scrub tech I worked with had developed a very elegant method of minimizing the amount of sterile packs that are opened at the beginning of the case to minimize people running in and out of the room. And so this is another area that is available to optimize for a particular facility. The temperature, humidity, and pressurization are all mentioned under that ASHRAE specification. There may be some overlap with other guidelines. I'm not 100% sure on those. The temperature and humidity are going to be more indirect effects. The pressurization is to isolate the operating room from the environment of the non-sterile area. And this, again, is specified under ASHRAE. And this is thought to prevent less clean air entering the operating room.
So most infection preventionists have some basic knowledge of their HVAC systems, and especially after the COVID-19 pandemic, where, that was a very hot topic for mitigation strategies. But I was intrigued by the discussion around the unidirectional airflow or UDAF ventilation systems versus the non-UDAF ventilation systems, and the comment that the UDAF systems may be erroneously labeled as laminar. Can you talk a little bit about the two systems in relation to this particular study?
Yes, the term laminar airflow dates back to the early 60s. Willis Whitfield, who is credited with inventing the unidirectional airflow cleanroom system, and actually was one of the early users of the term. Later, he was interviewed decades later, and he said, that's really just a generic term. It's like saying turbo or a super or something. It really doesn't have a technical description. As I surveyed the literature, I think the German DIN specification for healthcare environments has the best quantifiable definition of true laminar airflow. And this is when the flow lines are parallel to each other. There's no disturbance, allowing air particles that are generated in that environment to move sideways. And this is called turbulence intensity. Their specification is a turbulence intensity less than 5%. That's very difficult to achieve in the low volume 30 air change per hour systems that ASHRAE prescribes. This is something that takes higher airflows, even order of magnitude higher airflows than what that specification specifies. It's a term that's confused a lot of people over the years. What I hope would come out of discussions like this is understanding that's a very technical term. It's not used correctly in much of the historical literature. Please don't be confused. If you look at the current definitions, the unidirectional and non-unidirectional is really the best way to describe an airflow system. And even then, that's just a start at really describing the environment that the surgery is happening.
I must be a perpetrator of misusing that term. Oh no,
I am too. Yeah, it's okay. We're learning about definitions of stuff. And speaking of definitions, Dr. Harp, I'm curious, which definitions were used to determine the infections in patients? Did you use NHSN or NSQIP or some other?
Well, I'm at the boundary of what I know. What we did in this particular study is average 2-year follow-up by telephone and chart review of all these 80 patients and whether or not they were re-hospitalized for any type of infection or any treatment. And we even, when we could, reviewed clinic charts, and there were none. So on the other side of that, if something had happened, what would I have called a PJI? I've gone back to the current orthopedic literature, and that's an infection that requires a deep surgery of some type to go back and surgically into the joint to address an infection.
So what do you think that tells us, that out of the 80 patients that were followed, you didn't have any PJIs or SSIs?
Well, the best I can claim is it shows internal validity for our study. That is, at our facility, applying this technique and that benchmark of 450 MDT, that this seemed consistent with the results we produced. It really doesn't have any external validity, so any of your listeners that are interested in a research project, it's a study open to be replicated at other institutions. Hopefully it can gain more external validity. The skeptics would say that 80 is a pitifully small number and totally dismiss the paper. And I think that's a little short-sighted in this area in age of diversity and trying to look at different viewpoints. I think the engineering viewpoint to approach this subject is very valuable to orthopedic surgeons and hopefully your IP professionals.
I think we would all agree with that for sure.
Yeah, definitely. Also, based on the study, only 65% of the cases met the ultra clean air criteria at the back table zone. Can we infer any risk to the patient as a result of this particular situation?
Yes, and if you go back to the engineering model, how is that bioburden going to result in infection risk? It's going to be by transfer of instruments that were in that area, implants that were open and left open to the environment in that area, other means of transfer by those mechanisms into the wound. So it has a separate risk. It's certainly not zero, and that number is very high. I'm looking at in my small available patient base at measures to decrease that, which is an exciting area I may talk about at the end of the interview. But yes, it's too high.
Do you suspect that there will be future technologies to decrease critical zone contamination?
Oh, yes, and that's what I was alluding to in the last statement. I recently connected with a clean room industry group. They are very interested in the topic. There's a number of technologies in the clean room industry that I think can be transferred into the operating room. Some are available now. Some are maybe 10 years off. There's also available equipment such as clean room clothing that has a much different specification than our current surgical gowns that may be an area for improvement. So I think there's room with existing technology once we can tap into this science from clean room, which that technology's been around as long as operating rooms have, because they're both very closely related and they are constantly sharing from each other, and this technology transfer is occurring. But I think especially after the pandemic, and as you talked about earlier, we're much more aware of airborne diseases and what they can do, and this airborne contamination operating room is just another type of an airborne threat to health. And then the second thing is the awareness about ventilation and what that can and can't do. So I'm very excited about what the future holds for this topic.
Yeah, and I think to your point earlier around the fact that many of these patients could be subjected to a long-term treatment plan after acquiring a surgical site infection. This is not an area where we can rely on historical processes, but it seems critical that we're moving forward with new innovative ways to prevent these infections, and not just in patients who are going in for procedures, for orthopedic procedures, but really for all of our procedures where patients are at risk for surgical site infections.
Yeah, exactly.
So that's great.
And I agree. It's a very complicated phenomenon. The thing about orthopedics is really there's no tolerance for bacteria to be touching the implant in my mind. Other surgical procedures are more soft tissue related, where there's not a big void space that has no vascular contact. I think it may not be as critical, but I think the principles will benefit everybody, and not just in the operating room, but other areas of the hospital, such as the cath lab, protective environments for cancer or immunosuppressed patients.
Mm-hmm. Dr. Harp, this is a really exciting topic, like I said. What are some of the key takeaways you have for our listeners?
Well, the key takeaway is to look at what happens in the public health field, for example, in water quality. where you don't look at the number of people that are sickened by some type of enteric illness and then go back and say they came from the same swimming area. You're proactive. You take water quality samples. You look for E. coli. The E. coli itself isn't toxic necessarily. It can be, of course, but it's an indicator organism. And the same principle is being applied here in the operating room. Let's don't look at the infection as the endpoint, as the outcome variable we're most worried about. Let's take a look at the whole process and look and have a conceptual model that's used in other areas of technology, such as pharmaceutical manufacturing, or even the compounding area downstairs in the hospital. And use those same concepts, apply it to the operating room, and let's look at the air quality instead of looking at the patient complication that occurs months or days later. Let's be proactive and not reactive.
An infection preventionist's mantra for sure. Proactive and prevention. Well, thank you so much for being on here today, Dr. Harp. We really appreciate the information. Again, it's really interesting. It's it's very technical and very applicable to what we're trying to do in the overarching scheme of things in infection prevention. So we really appreciate you.
AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Research Committee and Pat Stone and Jean Brandt at AGIC, and APIC staff Shanina Knighton, Chris Ruiz, Bobby Gulshin, Christine Miller, Kaylee Deaton, and Kelly Lynn Russell. We work in partnership with Human Factor and audio tech Blake Alphin. To hear other AGIC podcast episodes and to access information about this podcast and the field of infection prevention and control, go to our website at agicscienceintopractice.org. That's AJIC scienceintopractice.org.